Good afternoon. First of all, I'd like to thank all of you for joining us. And also, I'd like to thank CHEST and American College of Chest Physicians for arranging this webinar. It's a series of the webinar which is happening every few weeks to address the important issue as we navigate through the COVID-19. We all know that when it started last year, early in the year, we felt it would be a very short term, and we probably will be over with that. Going into it for like 15 months, we still are nowhere towards our end. We still have a long way to go. We keep on seeing the light in the beginning, and then, it kind of fade away when the cases started going in from the China to France to California and then New York, and then it has started going all over the world. We saw the science making it the advancement at the fastest pace, whether it was the randomized control trial trying to validate, prove or disprove any medication, or we saw the science coming up with the vaccine in the record time. We saw vaccines after vaccine coming in, and then we also saw some challenges related to the vaccine. So in this, we are going to deal with challenges to recovery, COVID-19 and beyond. We'll try to specifically focus on physician practices. We'll try to talk about the travel, the medical conference, and some anxiety and post-traumatic disorder. First of all, I'd like to welcome my panelists. We have an excellent panelist, Dr. Humayun Anjum. He's a chair for practice operation, and Dr. Deep Ramachandran. He's a vice chair for practice operation. I'm Dr. Salim Sarani. I serve as the adjunct clinical professor at Texas A&M College of Medicine, as well as College of Pharmacy. I also serve as an ex officio for practice operation and member for Clinical Pulmonary Network. So I'll pass to Dr. Humayun Anjum to introduce himself.
Thank you, Dr. Surani, and once again, welcome everybody. I would just take a brief moment, introduce myself. Currently, I'm a pulmonary and critical care practicing physician at Baylor Scott & White in Dallas. Just a few months ago, for the last 5 or 6 years, I've been involved in teaching. I was in Corpus Christi, Texas with the HCA Graduate Medical Education Program, and I served on the faculty for the Pulmonary and Critical Care Fellowship, as well as core faculty for the Internal Medicine Department. And I've been serving as the chair for practice operations since last year, been a member of this committee, started my career thanks to some of my mentors very early after my fellowship, and been very actively involved with CHEST since then. So once again, thank you for joining, and hopefully this is a good session for everybody.
Thank you, Dr. Anjum. And Dr. Deep Ramachandran.
Hey, thanks for the intro. My name's Deep Ramachandran. I'm a pulmonary critical care sleep doc. I am the vice chair for the practice operations network steering committee. I'm a pulmonary critical care sleep doc, and I am currently working at Sleep Doc Direct, which is a online telehealth sleep business that I have created, and I'm doing primarily telehealth, and I also do pulmonary ICU medicine as well. So it's great to be here with all of you.
Thank you, Dr. Ramachandran. One thing we'll do is that as we go along, if you have any question and answer, you can put it in a Q&A box so that we can try to address as many questions as possible. What we have done is we have compiled few questions which we have received from the folks who have registered, and try to lump into different sections. And then once we are done with those questions, we'll still try to take as many questions you have and try to answer and relieve all the anxiety and create a facts and no fears. So one of the things is what we are seeing in the world is after the COVID came in, we start seeing variant. We start seeing the British variant, B.1.1.7. Then we saw the South African variant, the Brazilian variant. Then we have a California variant, and we have a double variant in India. So my question is to Dr. Anjum, can you tell about the different variant which we are seeing it and globally, and what would be the implications of those variant, and how effective our vaccine would be, or one vaccine is better than the other?
Thank you, Dr. Surani. So I think it's interesting because, as you mentioned earlier on, that we were seeing light at the end of the tunnel, and we were like, things are going to be back to normal. We'll be traveling again. We'll be doing, whatever we did before this pandemic era. And interestingly enough, these variants hit, which is not unexpected because, with the RNA viruses, as we all know, the genetic mutations, as we call them, are very common. And the same thing applies to the influenza virus. So this was not surprising, but again, something that is concerning. And they've been emerging all around the world. We've been seeing them in the US as well. Now, in the US, routinely, these variations are monitored through sequence-based surveillance, some of the laboratory studies, and epidemiological investigations. And they have developed an interagency in the US that have developed a scheme for these variants. And they've broken down these variants into three major variants. Number one being what we call as a VOI, variant of interest. Number two are the variants of concerns. And those were the ones that you had, I think, alluded to coming from different areas of the world. And then there are variants of high consequence, which again, we know can be very dangerous for that matter. Now, the implications of these variants are, I think, threefold if you look into it. Number one, are these variants more contagious? Number two, can they cause severe disease as compared to what we have seen before? And number three, being the most important thing, is that if these variants are different, then do we change our management as to how do we take care of these patients in the hospital or otherwise? And are the vaccination going to be effective for these variants? So some of the variants which are concerning at this time, as you had mentioned again, were B117, B1351, which was a South African variant, P1, which came from Brazil, B1427 and 429, which are the Californian variants. And these have been the variants that are being studied mostly right now. We, again, don't have a clear answer as to what are we going to see with these variants. We know one thing for sure, that these variants are definitely more contagious because we've seen that people carry these viruses in their mouth and in their nares, and these variants are definitely more contagious. So yes, the spread is going to be more, but again, we're hoping that the vaccination is effective. As you had asked if vaccination is going to be effective, up till now, we know that these variants have been accounted for in most of the vaccinations, and there is no data to suggest that one vaccine is better than the other. Of course, there's some differences, as we know, in the effectiveness of some of the vaccines. But again, I think the data is not very clear as to how this would change the way we would manage the patients. But one thing is for sure, that we have to be very careful, as these viruses, especially these variants, are definitely more contagious. So these social distancing measures and implementing a widespread vaccination strategy will always be of great importance, I think.
Thank you, Dr. Anjum, for a very explicit and detailed answer. One of the key things is that, yes, the variants are there. Second most important point is the vaccines are working, and we need to get the vaccine taken. The third thing is a lot of the vaccine makers are also monitoring the variant, and they're trying to come up with the, even if needed, if they feel that it becomes an area of concern where the current vaccine may not protect, then they're also able to develop a booster vaccine which can address those issues. So at least there is a good thing at the light at the end of the tunnel, and everyone should try to get the vaccine as soon as we can get it. Fortunately, we are able to have more vaccine available as the day goes by. Dr. Anjum, I have another question for you, which came from the viewer, which is it safe to go to a restaurant and gym? We have been kind of getting bored being in the hospital, being in the home, and trying to just get a Grubhub and order delivery done. When can we safely go to the restaurant? When can we safely go to gym? Because gym was classified as a high-risk area.
Absolutely. And I think all of us share the same feeling of being frustrated and not being able to do these things. I think, again, unfortunately, nobody has a clear cut answer as to what would be the time where you can say it can be done safely. But again, I think as we have progressed through this pandemic, especially with all the vaccinations coming out, I think we still have hope. Once again, April 19th, they're saying that all the adults in the US would be eligible to get the vaccination. So I think if about 75, 80% of the population gets vaccinated, herd immunity starts building up. And we can hope that we can come to an end with this pandemic. In terms of I think, restaurants or public gatherings, it is very important to keep enforcing the physical distancing measures, making sure that the restaurant that you're going to has good ventilation strategies. Preferably, if they have outdoor seating, then make use of that and sit outside. Making sure that all the disinfection measures are taken, making sure that everybody is wearing a mask, employees as well as people who are visiting that restaurant, keeping that 6 feet distance is important. So I think just the common things that we've been doing throughout this pandemic will be important to ensure the safety. In terms of the gym, it becomes a little tricky. The advice is that if you're involved in high intensity training, then probably it's not a good idea, because those are the things that you are very close to each other. Again, equipment such as yoga mats and other things which are very hard to clean is not advisable. So if you want to be involved in those sort of activities, it's preferable that you do it at home or somewhere else. If you're going to the gym and you're using some of the gym equipment, making sure that you sanitize it, disinfect it, let it be there for 2 minutes, making sure that you wear your mask. Again, 6 feet distance is important, and making sure that you take some of the measures that we routinely did not take before, such as, I was talking to my friend, so he goes to the gym. He's been a gym lover. It's very hard for him to stay at home, but there's so many new things that have come out, and I think they've like virtual training is there these days, so people are making use of that. There's Peloton, some other gym equipment that people are getting at home, getting those fitness trainers virtually and trying to do that. But he likes to go to the gym, so he's like, I'm going to go, but he's taking all the measures. So he tries to, before he would go from work, use the locker room. So one thing that he's done is he doesn't go to the locker room. So he's not very close to people. He, changes his clothes, goes over there, spend as less time as possible. Just go there, do your stuff, get out of there, sanitize your hand, come home, change your clothes quickly before making any encounters with your family. So I think just the common things that we've been practicing all along, we still need to enforce those things.
Thank you, Dr. Anjum. I think going in the same direction, but moving forward, I think when the pandemic came in, the community transmission was very high. We were going in and seeing the patient by the phone or by the FaceTime or any, not really the FaceTime, but the protected visual telehealth. So I think Dr. Ramchandran has been kind of doing a lot of it. When is the best time to go from transition from telehealth and going to an in-person visit? When is the safe time? And what do you think, Dr. Deep?
So that's a good question. So I think it's important to think about safety in sort of this sort of relative spectrum. So there's no such thing as being absolutely safe, and there's no such thing as being absolutely dangerous. But I think when it comes to safety and when it's okay to go back to the doctor's office, I think it behooves us as healthcare providers, both as physicians, as hospitals and offices, is to try to make it as safe as possible for patients. And so in doing that, we can sort of give patients the confidence that they can, that okay, hey, it's okay to go back to the doctor's office. And I think the way that we get back to having patients feel like they're safe to come to the doctor's office, have them come out to the doctor's office, is to have clear guidelines for our practices and make sure that they are transparent, make sure that those guidelines are understood by all the various different members of the clinic environment. So everybody from the front office staff to the physicians, the people who check them out. We're all sort of on the same team. We're all on the same page. We all know what we need to do. So all the different measures that we're going to put in place, we have to make sure that they're understood by all the different team members, and that they're universally practiced. And so those are things like making sure we're masking in all areas, making sure that we're sanitizing our hands. And I remember that when we first started having these discussions at the beginning of the pandemic, how do we bring patients in and how do we make sure that they're confident, is when you clean their hands, make sure that they see you doing it, so that they know that everybody is doing this, and that they're in a safe environment, and that they see everybody with their mask on, not under the nose, but make sure they're actually on. It's surprising how often you see, even as physicians, we walk around the hospital and you see somebody wearing that mask sort of off. And so what that is that it's a sort of a signal to people, to other patients, that, okay, maybe things are a little bit lax, and maybe safety standards aren't quite as good as they are. So I think, it is safe to go back to the office. And I think we as physicians should make sure that we're practicing sort of these high standards, and we're holding ourselves to those standards and holding each other to these standards, that we're communicating with patients that when you come into the office, this is what you can expect, that all the people who are taking care of you along this chain are making sure that we're keeping everything clean, that we're doing everything to try to make sure that you are safe, and that we're practicing all these things universally.
Thank you, Dr. Deep. What you're saying is live by example and practice what you preach. I think let's see if Dr. Anjum, do you have any comment on the same area? What are the guidelines regarding going, seeing the patient in the office, or are there any guidelines?
I think the Deep has pretty much summed up everything. Again, there are no strict guidelines. I think by this time it's okay. Once again, same thing that Deep had mentioned. There is no such thing as being completely 100% safe, or this is a very dangerous practice. You just have to weigh your options. One thing that is being suggested again is that, I'm not going to go into what Deep has already mentioned, but trying to talk to your patients, communicate to your patients, and usually they're suggesting that at least 48 hours before, if somebody has an appointment, trying to call them and see if there's been a certain change in their condition, see if they've been exposed, see if they're having any other symptoms, so that way you can triage your patients a little bit better in terms of that.
Thank you, Dr. Anjum and Dr. Deep. Talking in the same line, patients are coming in to the office. Should we, that's a question I think I'll put it to Deep. Since the patients are coming, should we deal with the possible COVID exposure in our office, like patients and the other patients waiting in the office, from patient to our staff to patient, and vice versa? Or are there certain practices which should we be focusing on, certain things which are very high risk and we need to avoid it, and certain things which we can easily do it? Dr. Ramchandran?
So there's lots of different sort of ways that we can think about this. And to go back to the question about the guidelines, there's no, as Dr. Anjum had mentioned, there's no specific, there are guidelines, but remember, the thing about this pandemic is things have moved so fast that the guidelines quickly become obsolete. So, recently there was this thing from the CDC about surfaces, and, that we don't have to, that the virus doesn't survive on surfaces. It's very low risk, but that doesn't mean we should stop cleaning surfaces. So we are still cleaning surfaces in all hospital environments, that we're still doing that in the office. And so one other thing that's brought up, as you mentioned, is how do we differentiate things between, a vaccinated person and an unvaccinated person. So now we have this idea that vaccinated people, as we've seen in the media that have been publicized, that the idea that vaccinated people can meet in small groups. But remember that in the office setting, as physicians, we are from multiple different cohorts, multiple different settings, so we still have to mask. And there'll be patients who say, well, I'm vaccinated. Do I still need to mask? And unfortunately, yes, the answer is yes. For the time being, you still do need to mask, because while it's looking more and more like, people who are wearing masks probably can transmit the virus or have very low risk to transmit the virus, the research is still ongoing. And I hope that we can ultimately get to the point where vaccinated people do not need to mask, but we're just not there yet. So for the time being, at least in the office setting, yes, we do need to mandate that people still wear masks. In terms of COVID exposures, if we do as offices need to be prepared, and we have been prepared about what do you do when you have, patient calls in and says, well, I was in your office yesterday and I was diagnosed with COVID. So what needs to happen in the office now? So the one nice thing about being vaccinated is that you don't really need to do much of anything if you've been vaccinated and you have no symptoms. So as a healthcare worker, if I've been exposed to somebody and I've been fully vaccinated, I'm not immunocompromised. If I've been vaccinated and I've been exposed to somebody who has COVID, I don't really need to do anything. I don't need to quarantine myself. As long as I'm feeling okay, then I'm fine. And that's different than if you've been unvaccinated. So if you have an unvaccinated healthcare worker, a nurse, a doctor who's been exposed, then you do need to go through that process of potentially quarantining up to 10 days, potentially doing testing. So those are things we still need to look at. So the good news is, if you're vaccinated, if you have a patient who's vaccinated, who's been exposed to the virus, you can tell them that, if you're exposed and you're feeling fine, then you don't really need to change anything or do anything differently. So that's one positive thing that's come from vaccinations. We're still wearing the mask, but at least we can go out a bit more freely. We don't have to worry as much about the exposures. And if we do have an exposure, as a person who's vaccinated, if you're asymptomatic, then you do not need to quarantine.
Thank you, Dr. Deep. One of the questions that pop up in the Q&A box, are face masks necessary in open area like street, parks, or any open area? One of the thing is that if you're in a park where there's nobody in 50 feet distance or 20 feet distance from you, then obviously it makes sense not to wear the mask. But again, if there are a lot of people around, it's just like you're driving in your lane, but what is the guarantee somebody doesn't intrude in your lane? Somebody doesn't break that 6 feet barrier or 4 feet barrier. So that is the reason that we still recommend, if you're in the park or where there are a lot of public gathering, then we need to work on it. Also, the main thing is that, if you can guarantee that nobody is going to invade your lane, that's a different thing.
I don't know how you guys.
Do you have any sense? Say.
Yeah, so I think this is different for different people. So I'd be interested to see what you guys do. Like when I go out, just outside of my house, I go down the street, I go for a walk. I don't wear a mask because, I live in a town and there's not a lot of people around. So you walk down the street, there's plenty of space if I'm walking on a sidewalk. And if someone's coming the other way, I can walk and go to the other side of the street. So I don't wear a mask when I go out generally. But if I'm out like you said, in a crowded place, like if I was outside of a crowded place, or if I was to go to an outdoor concert, then yes, I personally would. My wife is different. Now, when we go walking, she wears her mask all the time. And so, I don't begrudge anybody doing whatever they feel they need to do to feel safe. But I personally, when I go out for a walk and there's nobody around, I don't wear a mask. I don't know about you. Anjum, what do you do?
No, I think it was weird. Just like, I think like a few days ago, I went out, we just moved here, and there's a nice park just down our street. And I took my son there, and we got out of the car, and I just forgot to put the mask on. And then and then we just started walking, and we walked like a considerable distance. And then I was just looking around, and I was looking at a lot of people, and about 90% of the people in that, I mean, it's a nice park with, some walking trail along the lake that we have. and most of the people were actually not wearing a mask. And I just realized all of a sudden, I was like, something is missing, because you're so used to, putting that on once you get out of the car. But most of the people that I've seen have not been wearing it. And I am kind of conflicted. And that's when I started thinking, I was like, should I wear a mask, go back to the car, grab it? Or should I be and just make sure that I don't, come in close contact with anybody? And then, as you said, if I see somebody who's coming my way and I'm too close to them, then I just move out of the way. I just don't know what is the right answer, I think, in that sense. Again, that thought that we are vaccinated also gives you a little peace, I guess, in that sense. You're like, I'm okay. Yes, there is some effectiveness to the vaccine. Of course, taking all your precautions, but this mask part, I think, is still very debatable and very individual, I think, in that sense. Again, I think, as both of you all mentioned, just taking your precautions, making sure that you still do what you're supposed to do. But I think if you're, not in close contact, in a big space, open space, then it might be okay to be without the mask.
Thank you very much for both of your answers. So it seemed like if the road is open, there's no other car, you can drive faster. If there's some other car, you need to make sure you protect not only yourself from them, but themselves from you. But let's change a gear a little bit. I think, one of the things is we had a lot of the cases that started coming in for the COVID. The community transmission was high. We went from the in-person to the tele, and then now we're talking about tele to in-person. So I think I'll put this question to Deep, is that what he thinks about the telehealth role. We were talking about the telemedicine before. There's a shortage of the physician, and what do we think is the role of telehealth and back to telehealth to in-person and in-person to telehealth, and what patient we should think of seeing in person, what patient we think of telehealth. So I'll put it to Deep, and then I'll also go back to Dr. Anjum to let him put his thoughts.
So I've switched to telehealth now. So I say don't go back to the office. Just stay home and keep doing telehealth. I'm kidding. So the switch is one of the things we kind of have to handle carefully, and I think it's something that we had a lot of experience with, right? Because we did this switch before, where we're doing at home, we were doing normal in-office care, and then we kind of transitioned to, all right, we got to get more careful with this, and then we switched mostly to telehealth, and then people were doing, maybe 2/3 telehealth and 1/3 in person. And now it's kind of switched back again. So, as I talk to more and more people, I'm hearing that, they were doing well, maybe 3/4 in person, 2/3 in person, and 1/3 telehealth. And I think that's probably sort of the way things are going to go, or at least stay from that transition. So I think we got to handle that flip carefully. And as I mentioned before, part of it is making sure that we're giving people the confidence to come back, and that we're telling them that it's safe to safe to come back, because we're putting in all these measures. But one of the things we got to do is, I think Anjum also mentioned this, is triaging. So we were doing that before when we were in person and we started to transition, is that we have to triage patients correctly. We have to screen patients. So those are two things that we got to do properly. So one is when we triage, if someone calls in with symptoms, you correctly triage them to say, all right, is this person safe to come into the office, or should they be seen by a telehealth visit? And there's a couple of things to look at. Number one is the safety. Is the patient safe themselves to come into the office? So do they have symptoms? Could they possibly spread something? Could they possibly spread COVID-19 to other people in the office? And the other person is the safety of the office to the patient. So if a patient is high risk, if they are immunocompromised, if they're on steroids. So we see this with the vaccine, where people who are immunocompromised don't really build up good antibody levels. So sort of the safety of the patient to the office and the safety of the office to the patient. So if patients have a lot of symptoms, those are people that we should triage to telehealth. If the patient has if the patient is high risk, immunocompromised, on steroids, have immunocompromising conditions, those are people we should probably triage to telehealth. And then there's also the screening process where we're looking for patient symptoms. So those are things that we have to look at when we're looking at triaging patients to how they should come in or whether they should stay at home.
Before I go to Dr. Anjum, Dr. Deep, I think I'd like to ask you a follow-up question, which pop up in the Q&A chat box. The attendee have a question. We have a program with home visits and outpatient clinic visit with a long hauler protocol. Telehealth is used to follow up, but we have had a lot of technical issue with our tablets, computer, phones, etc. Is there a system out there to partner with that supplies the technology? You just mentioned that you switched to telehealth. I think if I do from home, I think I have too many honeydews to do from at home, so I'll rather run out of home. But how would you respond to that?
So I would. So I don't want to say I want to be agnostic and not promote one particular product over another. So there's lots of different telehealth platforms. One thing to remember is that during this pandemic, that the HIPAA rules have not been waived, but they are sort of turning a blind eye to HIPAA compliance in terms of telehealth platforms. So platforms that were traditionally not considered HIPAA compliant, like for example, Zoom, or I'm not sure that FaceTime is HIPAA compliant, but you can use more common platforms that were not necessarily considered HIPAA compliant before. You can use those platforms now, and the government has said that they will not enforce the HIPAA rules if you're doing it, if you're doing things in the interest of the patient. So you can feel free to try a multitude of different platforms. You don't have to stick to one, and even if it's not necessarily HIPAA compliant, you can do FaceTime, you can do Google Meet. I personally use Doximity, Doxy.me is another one. But I don't know that there's necessarily one perfect platform. It's really which one the patient can use. And this is a problem with telehealth. This is a good point to make, that a lot of my patients, like, if you have a lot of patients above 65, a lot of Medicare age patients, a lot of them they cannot do it. They can't log in. A lot of them don't have emails. A lot of older folks or folks that can't afford a cell phone or cell phone plan. So those are things that you also have to plan for, is that not everybody can do telehealth because of challenges with the technology or because of financial constraints, that they just can't afford a platform like that. So those are things that you definitely have to look at when we're transitioning to telehealth and away from telehealth.
Thank you, Dr. Deep. I think, Dr. Anjum, I'll ask the same question, your thoughts about the telehealth. And also I'll ask you another question, that what is the current state of the insurance coverage? Because obviously you can see the patient all day long. If the third party doesn't pay you, it doesn't, when rubber meets the road, it would not happen. So what is your thought on that?
No, I think Deep is the expert. I'm not going to go, go into more details regarding that. But he's right. I think we've come across several of these platforms that are available out there. Some of the online approved websites or platforms that he's mentioned are also there. But again, with the challenges, it becomes a little tough. And we've all, I think, been through it. That after seeing patients during this pandemic. For a few months, it was good for us because we could at least see these patients, evaluate these patients, give them the advice. And for them, it was good because, if they needed a refill on their medication, some important issue came up, we could discuss it. But after a while, it has started to feel that, we can't just keep on doing televisits all the time. We needed to see these patients in person. So I think that's another challenge. And then that same complaint came from the patients too, that they did not feel that they were getting that same sort of attention, or it wasn't what we expect with a face-to-face visit. So yeah, the challenges are there. I think it's going to be a slow process where some of the visits will still be televisits, and most of the visits finally are going to be the face-to-face visits as we've done previously. Regarding the insurance coverage, it has been covered. It will, Centers for Medicare and other private insurances, they cover the audio visits as well as the video visits. You get paid differently for those visits. For the audio visits, the visits are based on time. So there's 3 levels for the visits: 5 to 10 minutes, 11 to 20 minutes, and then 21 to 30 minutes, and they're paid accordingly. The video visits, on the other hand, are paid as if you're doing a face-to-face encounter. So if you're using some of the video platforms, whether that's FaceTime, Google Meet, or Doxy, and seeing patients through that, then you can bill just how you would in a face-to-face encounter. And this would continue. Again, we don't know exactly how long, but till the pandemic is there, the definition of pandemic remains. They will continue to pay for it. And the same thing has been in the hospitals as well, that people who have COVID and are uninsured, there's a different entity that has taken the responsibility. So the physicians do get paid for those uninsured COVID patients that are being admitted and taken care of in the hospitals as well. So yes, you get paid for your hard work. It just depends on what you're doing and what would be the best solution for you and for your patients.
Thank you, Dr. Anjum. I think the changing the gear a little bit, I think we go into the traveling mode. So I think, we'll talk about the global travel to the medical conference. So my question is for Deep, what is the guideline if you think of going to the medical conference or some other places where there is a gathering? Are there any guidelines available from CDC or any agency if you know of?
So what the CDC has said recently is that we can now start to travel. They recommend continuing to mask when you're in public places. The only thing that I think the things that are significantly changed from what we were doing before in terms of universal masking and universal cleaning is that, number one, is that vaccinated people can travel and do not have to quarantine when traveling within the United States, either before leaving or upon arrival. Number two, they don't need a COVID-19 test. And that's according to the CDC. Now, you may still run into, a company that says, okay, when you come here, you still need to get a test. But at least according to CDC guidelines, they don't specify that you need to either quarantine or get a test for travel within the United States, as long as you're asymptomatic and you've been vaccinated. And then upon, when you're out and about, you don't need to isolate if you're exposed to somebody who has COVID-19. In terms of travel, they say that travel is okay, but they have said that they would avoid unnecessary travel. So take that to me what it is, what you will. They recommend not going into large crowds. So that would mean things like a medical conference would probably be it's an inside event with air conditioning. So that would make that sort of a relatively higher risk endeavor. CHEST is coming up later in October. I'm hoping that those things would be that by that time we've gotten towards universal immunity and that we can the CDC can sort of lax some of those guidelines. But that's something that we're going to have to continue to watch. It's sort of a day-to-day thing. If you're running a practice or traveling, that's something that you should continue to watch and log on to the CDC website to stay abreast of, because things are changing day to day, and hopefully they're changing for the better. Although, Anjum had talked about some of these mutant strains that we're seeing. So yeah, that's something we're gonna have to stay abreast of.
Thank you, Deep. One of the things is talking about the CHEST, they did modify. If you look at the venue, it was supposed to be in Vancouver, but now it's going to be in Orlando. One of the things is it's going to be hybrid this year. Some people, if they want, they can attend in person, and some folks can attend by the tele mode or a webinar. One of the things is that they have selected a venue which is pretty big, that whoever is attending in person, they can try to ensure that we do the physical distancing and follow all the public health measures. Now, let me ask a question to Dr. Anjum. What about the domestic and international travel? I know there has been some changes lately, which has been implemented for the international travel, especially when you're coming back. Can you take on that question?
Yes, I think again, domestic travel is different. International travel, they've divided some of the countries into different colors. Especially UK has come up with a very nice strategy. So they've assigned a different sort of risk category to certain countries. And if you are traveling from that country, then the policies for that risk category will have to be followed accordingly. Some of the countries will require you to quarantine regardless of, however you're feeling, whether you're symptomatic or asymptomatic. And some of the nations are not doing it. So it just depends geographically what you're doing and where you're traveling to. A lot of people, I think, are trying to change the way they used to travel. I think instead of taking short vacations, they're taking probably a little longer vacation. They're trying to stay in one area. So if you're going to a place, you try to stay in that place and kind of roam around and explore that place sort of in its entirety, rather than going to multiple places. So Airbnbs and things of that sort are gaining a lot of popularity because people just stay put in one location and then explore that area all over the that place. So it just depends, I think, what your travel plans are. Again, it is not recommended that if you don't need to travel, then definitely don't travel. But if it comes to that, then some of those precautions will need to be taken, and you'll have to follow the guidelines that have been established by different countries for travel based on the risk category.
Thank you, Dr. Anjum. So it means that if you don't want to travel, don't need to travel, don't go there. But if you're going there, just try to make sure, go in a place, don't try to go on a multiple country tour, just restrict yourself to as minimum as possible. One of the things is the question is coming back to Deep is about the telehealth. I think, since he's doing the telehealth, we see a lot of variants coming in. Now B117, which is a very, very prevalent variant in our country. We are also seeing some South African variant, California variant is there. In the view of the variant coming in, and there is some concern that the vaccine may not be able to protect. But what we have seen some very good result with the Pfizer vaccine for the South African variant, very effective. The vaccines were effective for the UK variant. If there's some other variant pops up or keep on popping up, do you think that depending on the community transmission or variant coming in, would it be advisable again to switch from in-person, go to a lot of people to telehealth? So Deep, you want to comment on that?
Sure. So, yeah, it's tough with these variants because we're seeing the light at the end of the tunnel with COVID. Now that we have the vaccine, I think we're hopeful that the vaccine is going to work, and we've seen meaningful data that the vaccines, at least the Moderna and Pfizer, appear to be effective for a lot of these variants. And so, if we can vaccinate as many people as possible, then hopefully we won't have as many of the variants and the emergence of new variants. But I think we have to be ready to flip the switch again. And it may not be a national thing. Hopefully it's not a national thing, but there may be times where, we're seeing this in Michigan now, where you're having flare-ups in certain areas and you have to sort of flip the switch back and say, okay, maybe it's time we didn't bring people into the office again or brought less people in the office again. And some of this is out of concern for patient safety. A lot of it is what we're seeing in Michigan is out of concern for, preserving the hospital beds and preserving the hospital infrastructure. And so you're not bringing in a lot of, and not bringing a lot of surgeries and elective surgeries and procedures into the hospital, just so you're maintaining bed capacity. So there's going to continue to be flare-ups like this as long as COVID is out there. I don't know for how long that's going to continue for, but it's going to be there, and we have to continue to be vigilant. We have to continue to be ready to flip the switch back and to look at, all right, maybe we got to go back to sort of hibernation mode with our health system and start going back to telehealth. So those are things that we're going to continue to have to deal with. And so even when COVID is gone, it's not going to be gone. We still have to stay vigilant and keep watching out for it.
Thank you, Deep. And there's a question in the chat box. I think there have been several questions coming in, and I've been trying to address, trying to just keep the flow in the same direction. There's a question now. What have you heard about how long antibody will last after vaccine? Is there an antibody test that differentiate that is different than what we already have? And also, the thing is that the people who have a vaccine, they got the COVID 3 months prior. Actually, have seen people who have had the vaccine got COVID after receiving vaccine greater than 3 months prior. One of the things I can tell you that both Pfizer and Moderna, they are following the patients who have received the vaccine, and they have come out and said that up to 6 months their vaccine is validated. A lot of the people are thinking that the vaccine is validated or effective only for 6 months, which is not true, because this is a new vaccine. So they're still tracking in, and hope is that it will last longer than maybe 1.5 or 2 years. Now, people who have got the COVID after vaccine, most of the vaccines are not 100%, whether you have a 90% efficacy, 82% efficacy, or 95% efficacy. It does mean that people still can get the COVID. But one thing is that all the vaccines have been shown to be efficacious in preventing serious illness like hospitalization and death. Dr. Anjum, you want to add anything on that response?
No, I think that's you've given a good summary. I mean, some studies are even suggesting up to 8 months, but I think generally it's varying between somewhere 5 to 8 months. The immunity that they're saying should last at least after getting the vaccination. Again, things are ever changing. Strains are coming in. Virus is changing, and again, how we know with the coronaviruses, corona means the crown. So that's what they are. It's a crown, and they generate these spike proteins. So it's very hard to keep a track of these things and say that this variation has caused this sort of infection unless you're able to track these spike proteins. And again, I think one of the concerns that people have is that my IgM is positive or my IgG is positive. Again, these antibodies, if you have been infected with COVID, the only time that you can get these antibodies is through infection. The only way you would be able to differentiate is, what kind of infection is through those spike proteins, where you'll be able to see if there is any variation. So again, the data is ever changing. Still, the companies are claiming that most of these strains are accounted for. Again, they're not 100%. So as you said, some of the infections will be expected, but hope is that they don't get very serious. But again, as I mentioned initially, that these strains are known to be more contagious. So keep taking the precautions.
Thank you, Dr. Anjum. One of the things is that, changing the gear a little bit, we talk about the mental health. 19.7% of the adult in US suffer from mental health. 9.7% of the children in the US suffered from mental health. 60% of them are not having any access to healthcare. That was before the COVID. Now, we published a couple of papers, and that with the COVID, the number of the mental health issue, whether you take anxiety, the depression, the PTSD, is increasing. And people who had the COVID, they also have a high incidence of PTSD. So what would you say about that?
No, definitely. That's a great point. I think we've been seeing in our practice, at least, talking to our patients who just with the fear of having COVID, they get so anxious. People who've had COVID, we've noticed that when they're in the hospital, even though that they're doing okay with their numbers, they just start getting very anxious with anxiety. They start hyperventilating, and then just things go south from there onwards. So just hearing the name that I have COVID creates that sort of anxiety. And again, we've been dealing with mental health problems for different reasons in our community all over the nation. COVID has made it worse, for sure. Some things that I think that are suggested that you should do is, number one, I think try to limit with interaction with social media. I'm not saying that you should not read about the news. I'm not saying that you should not watch television. You should not be up to date, but try to limit it in the sense that don't let it rule your life. Don't just like sit and watch every single thing. There's tons of information there. We've even talked about this thing previously in our chest physician journal article, that what we call as the COVID infodemic. Which means that there's just so much information out there, and a lot of that information is misinformation. It creates unnecessary anxiety, unnecessary trauma. So try to look up validated information and don't go overboard. Number two, I think it's important to talk to your colleagues, people that you trust, your friends, your family. If you have any issues, if you're having any problems, do talk to them. Do explain what you're going through. There is help out there. People can help you. And this is a situation where families come together, where friends come together, and they help each other out. So I think that's very important to have a good support system, so that way you can talk and address these issues. All of us go through it. There is nothing wrong with it. It's very natural. And again, as you said, COVID has made it worse. So those are the two big things. And again, remembering that there are services available, suicide hotline, other issues with, psychiatric illnesses. There's so much help out there that I think it's better to seek help rather than, hide it inside and then suffer in the longer run.
Thank you very much, Dr. Anjum. I think before I go into some of the more questions and get your feedback, I just want to take this opportunity to thank all of the frontline workers, again, from the bottom of the heart, because what you're mentioning is what we have all gone through. We have seen people dying like never before. We have seen people getting on the ventilator, and it was very tough to get them liberated from the mechanical ventilator. Our hearts goes to healthcare worker who have lost their life while trying to save the life. More than 3,000 healthcare worker in this country has lost their life. So I think I'd like to thank all of them who are in the front line, all of the people whose life have been lost while trying to save the life of the other. Their life has not gone in vain. We'll just continue our fight with the COVID, and we'll try to make sure that we live up to their hard work and dedication which they have shown. And our thanks again go to all the frontline worker, especially pulmonary critical care and any physicians, nurses, respiratory therapists, and even custodian worker. Our hats off to them. Again, I think, now what, in the interest of the time, I think I'll take one more question, and then I'll try to have the panelists give their closing remarks in case if we miss something. One of the question is very interesting, and I think everyone want to know that, but there's no right answer. The question is, when do you expect us to get our life back to normal? I'll start with Dr. Anjum, Deep, and then I'll give my comments too.
Very tough one, a very tough one. And again, I think, as you said, nobody has a clear answer. Just about, it's about just about that time where we were saying that, things are going to be a little bit better. We start seeing these variants, but hopefully, again, I think we still have to be hopeful. That's what keeps us alive. We have seen that we have progressed. We have learned new strategies. This has been a life, sort of changing experience. I have never experienced anything like it. None of us have. I mean, seeing so many ARDS patients at the same time, doing so many procedures, taking care of them. So I think things will change. When are they going to get back completely to be, normal before, what we had before this pandemic? I am not sure. And I'm not even sure if this is maybe the new normal. This is probably how the world is going to be, that we'll always be told to take some precautions that will always be in place. And the hope is that, we get the strength to just go along, push along, and take care of our patients and help people.
Deep?
True. I'm glad you went first on that one, Andrew. I don't know.
I don't know. Yeah.
What's normal? I mean,
what's normal?
Is this the new normal? So yeah, I'm hoping that, like you said, as we transition, but who knows with the variants. So I think we have to be vigilant, and we kind of have to just kind of let go a little bit. Say, okay, we just kind of roll with it and do whatever we can. It's interesting to think about what's going to happen with the masks. Is that going to become the new normal? I mean, every winter we go through this flu epidemic and we lose tens of thousands of people. And are we now going to say, is that acceptable? Or do we mask as physicians? Do we all do universal masking again? Is that going to become a new normal every winter? So that's I don't know. I don't know the answer to that. But those are interesting things that we're going to have to look at down the road.
Thank you, Deep. One of the things is I'll try to share my thoughts too, because there has been a lot of things coming out from the WHO and the other nations. One of the things is we know that the vaccines do work. And to create the herd immunity, I think you have to get 70 to 80% of the people, either they get antibody from infection or they get the vaccination. But the thing is that since the whole world is very tightly connected, to get control on the COVID, it means you need to have a global herd immunity. And if you look at it, there's a real disparity between the developed country, the amount of vaccination which they're getting versus the developing country. There are so many countries who cannot get their hands on vaccination, even to vaccinate their front line or the high risk population. The COVAX, which is a group, through the United Nations and all that have got together, and they are going to help get 20% of the vaccine need for those countries, and they are still struggling to get it. So I think this is a time where the world needs to act together. If we want to see the light at the end of the tunnel, I think this is a global issue. This is not going to be the last pandemic which we have seen. There are more to come, and this is a test of the time how together we can work better. And hopefully, if we can work together, we can quickly see the light at the end of the tunnel. We are almost down to the time. There's some more questions, but what I'll do is we are left with almost 3 minutes. So I'll let Deep give some final comment, and then Dr. Anjum, and then we'll close the session. I know you all have to go back to the work. Deep?
All right. Well, thanks to Salim, Dr. Sarani for hosting this. Thanks to Chess for hosting this very important topic. I would think just my final thought is that, it's important to get our practices back up and running. We've seen, a little uptick in mortality from non-COVID diseases now. Some of those were mental diseases that Anjum had mentioned, but other things like lung cancer. So it's important to get those patients back into our offices, getting them back into the system and restart care on those patients to sort of prevent this sort of increasing mortality that we're seeing among non-COVID patients from our usual diseases that we usually treat.
Thank you, Deep. And Dr. Anjum?
Thank you, everybody. Thank you, Chest, again, for hosting this important webinar. Thanks, Deep, for being my partner. Thank you, Dr. Surani, for moderating it. And, once again, I think I agree with whatever you all have said, and just hope that, at some point in time, we can control this disease.
Thank you very much. Thank you, Dr. Anjum. Thank you, Dr. Ramchandran. And thank you, Chest, for providing us with an opportunity. And thank you to the audience who have sent their questions, attended, and took a 1 hour out of their precious time to join us. I'll pass it back to the Chess moderator. And thank you very much. You all have a good afternoon and evening.